Welcome, everybody. My name is Felix Eduardo Nayim. I am a doctor and geriatrician. I am master in social gerontology. I am president of Argentina Gerontological Association, AGA. Also presidente 22 World Congress of Gerontology and Geriatric, IAGG 2022, Buenos Aires, Argentina. I have the great honor to introduce Dr. Elena Moore, South Africa. Elena Moore is an associate professor at the University of Cape Town and member of the Care of Older Persons in Southern Africa Network. She is the author of 3 books: Generation, Gender and Negotiating Custom in South Africa. Her work has appeared in the Journal of Family Issues, Feminist Economies, Gender and Society, Critical Social Policies, Families, Relationship and Society, and the Journal of Southern Africa Study. She is currently editing special issues on family caregiving of older persons in Southern Africa with the International Journal of Care and Caring.
Good afternoon, everybody. My name is Elena Moore, and I'm a sociologist based at the University of Cape Town. I came to thinking and working on care of older persons as a family sociologist, and through a wider study on care and intergenerational relationships in South Africa specifically. Now, it was through this work that huge gaps in sociological understanding of family caregiving for older persons in South Africa, but also across the region, became very evident. So over the last 2 years, we've been developing a network to look specifically at the family care of older persons in the region, and it includes scholars from the region and elsewhere, as well as government officials, representatives from HelpAge and WHO, etc. We have a forthcoming special issue coming up on this topic, and it is mainly through this work that I will present ideas concerning the inequitable and unsustainable care practices related to the family care of older persons in the region. Now, before we delve into the historical, political, and economic conditions of care for older persons in the region and how they shape care context, I want to highlight 2 real cases of how care for older persons is experienced, in this case in the South African context. And it's through listening to these examples of how responsibilities for caring are actually practiced and negotiated. And this allows us to think about how these practices can be supported and enhanced. These examples, as I mentioned, are drawn from my study, and these particular examples that I will present today are based on the experiences of employed women who care for a co-resident older person. So the first case we'll look at is the case of Sandile. Now, Sandile is in the middle of this family map with the dotted circle. As you see, she's 40, and she is a nurse and the primary caregiver for her 72-year-old mother who has diabetes and recently had a stroke. Now, Sandile looks after her brother's 4 children who were co-residing with the grandmother before she had a stroke and required more care. So Sandile moved back into the family home to care for her mother and lives with her 2 children, her brother's children, and a cousin, Wally, who looks after the mother while Sandile is at work. So in the family map, we see a curved line, and everybody in that curved line is in the one household. Now, Sandile pays for her mother's medical insurance, funeral policies, and pays for the food that makes sure that she has a balanced diet. She also pays probably for her help in caring for her mother while she is at work. Again, the family map shows how care arrangements are pieced together not only when an older grandparent becomes ill, but also when there are several dependent children that the older person once cared for. Scholars have highlighted the gaps in social and economic policies that older persons, specifically grandmothers, have been cushioning for many years, and warned about the impact of the loss of such cushioning effects In this case, Sandila, like many other women, carry the care responsibility not only for the older person, but also for the other dependent children. The gendered inequality within this family is also evident. Sandila has 2 older male siblings, and she gets frustrated with the uneven responsibility she carries and the lack of adequate support, both financially and caring tasks she receives from these older siblings. She reflected on the various cognitive labor she engages in daily, whilst making sure her mother is well looked after. And she outlined the sacrifices she constantly makes in her day-to-day life. Now, the second case we're going to look at is Joy. Here, Joy, again, is in the dotted circle in the middle of the family map. You'll see a dotted curved line and a continuous curved line. These are representing 2 separate households, albeit they live on the same plot. So Joy here is a teacher, and she explained how she cares for an older aunt. Joy and her sister Anna effectively share a household and its responsibilities, although they live in 2 separated parts of the home. So Anna lives in the main house with her 1 daughter, her uncle Voyo, who's 67, her uncle's girlfriend, and her older aunt Zedwa, who's 69 and has a disability. The property is a family home consisting of a main house, a renovated garage, and 2 rental units in the backyard. The garage was converted into 2 rooms where Joy lives with her 2 children, Anna's other daughter, and a newborn. Now, despite being gainfully employed as a nurse, Joy is struggling to meet the financial needs of the household. This is due to the cost of her extensive caring responsibilities, which leave her financially and physically drained. Now, Joy took over the primary responsibility for her older aunt after she discovered that the aunt, who has diabetes, was not being cared for properly by her uncle. She reports here that when she came back, she could see that the auntie wasn't taking her medication correctly, and that she wasn't injecting in time, and she had to teach her how it was to be done. She also explained how the house was very messy, and that in particular the older auntie wasn't eating well and they weren't buying healthy food. Now, unfortunately, her sister Anna is unable to support her financially as she has significant debt, but Voyo and Zedwa, both over 60, receive the old age grant. Voyo doesn't share his with the broader household, and he has control over Zedwa's old age grant. Joy has requested that he contributes a portion to the shared costs, but he does not share the old age grant with her, although Joy is now responsible for paying for and taking care of the cooking, the food, and the general organization of the household. The complexity of social relations and household dynamics is evident in this family, who live beside each other and share many tasks, but material resources are kept separate. The gendered aspects of taking on practical care activities and also financing care, again, is highlighted in this case. So in this talk, we're going to think about the way in which families, and female caregivers in particular, are responsible for care of older members of the family, which is both unsustainable and inequitable. So I argue that the inequitable care practices stem from their location in highly unequal care contexts due to the unique political and colonial histories in the region. Moreover, they are unequal due to the way they coexist and are embedded in multiple care contexts, which has been characterized as a crisis of social reproduction. They're also unequal as they are largely ignored and silenced in authoritative policy texts, which are based on assumptions that the family will and can care and are silent on the conditions within which such care is experienced. Secondly, I'll argue that family care practices for older persons are unsustainable due to the rapidly aging context in Southern Africa, combined with the structure of social security for the elderly and other socioeconomic conditions. So in drawing on the concerns and challenges, I pay close attention to the dangers of homogenizing the Southern African context, where differences in histories, family living arrangements, policies, and the broader old age care economy create vast variation in outcomes for older persons and for carers, indicating the different ways in which care practices in the region have become unsustainable. I'll indicate how the reliance on female family caregivers protects the formal health system from being overburdened, and this cannot be sustained as more and more women enter the labour force and the population increasingly are aging. Now, thinking about the first part of inequitable care practices, we need to look at the unique colonial histories. So common across the region was the racialized and gendered marginalization and unique unequal access to the economy and services through distinct colonial histories. Now, the colonial legacies across the region resulted in generations of people being economically oppressed during their lives and unable to make provision for their old age. Moreover, the histories and practices of labor migration in the region for many decades resulted in shaping highly gendered practices of care and disruption of family life. So the oscillation of migrant workers also distorted generational and gendered care systems within society and families. For many decades, the vast majority of care to older persons fell to families, but to mainly women in rural areas. So whilst gendered and racialized practices of care continued for successive generations, it also shaped normative attitudes to care and who should provide care in families. Now, across the region, however, each country created unique care regimes during the colonial era, with some countries like South Africa, Zimbabwe, and Namibia introducing pension schemes and old age homes and legislative protection as early as the beginning of the 20th century. Such protections were not accessible to the majority of older persons, but they did create this infrastructure for the post-independent state to work within or work with. However, securing independence, albeit at different historical periods, resulted in major reforms of most areas of public policy. States had to consider how to transform and/or de-racialize existing care regimes, either through extending to African majority the privilege that up to then had been largely confined to a white minority or a minority, and to transform it, secondly, and most importantly, to render it more appropriate to the needs and norms of the African majority. Now, in some countries, the approach of deracialization proved insufficient and transformation too limited to address a range of inequalities in access to care. So across the region, different states inherited deeply unequal and poverty, which would only partially be mitigated by social protection and care regimes. What is common across the region, despite the presence of state grants and cash transfers, family support and civil society, including religious organizations, continue to play a critical role with large numbers of people dependent on kin for both financial and/or personal care, and extended families and religious families remain critical in the provision of care. So access to critical resources to support the care of older persons remains highly uneven and makes caregiving more challenging. Scholars in the past have noted that when these needs continue to be unmet, it is the care economy that fills the gaps, with the result that an already heavy workload becomes untenable. Now, the second part of thinking about inequitable practices is thinking about the multiple care contexts that exist in Southern Africa. Now, in Southern Africa, like elsewhere in the global South, when an older person requires care, a woman will do it. However, given the absence of adequate institutional care more broadly, it is highly likely that the same woman already assumes primary responsibility for the physical and financial care of children and the care for anyone living with a disability or HIV-related illness. Now, time use surveys in the region continue to highlight how women spend more time in caregiving activities compared to men. And due to the ongoing impact of HIV, COVID-19, and high levels of unemployment and poverty, this has been conceptualized as a heightened crisis of social reproduction. The literature has also shown us that older persons themselves are key caregivers to children and other family members. And as I mentioned, scholars have been highlighting the huge gaps in social and economic policies that older women were covering and cushioning, and they warned about the impact of this loss. So as I showed and demonstrated in the example, if an older person becomes ill, caregiving for the older person may be coupled with taking on extensive care responsibilities for younger generations that the older person once carried. In addition to this, and unique in the South African context, is that many households in the region, but specifically South Africa, are increasingly women-headed, with the number of female-headed households growing by 1.5 million households in the period 1997 to 2006. Now, by 2006, and over the last decade or two, women-headed households comprise around 40% of all households in the country. So the research indicates that women-headed households, though, are more financially vulnerable. They tend to be home to more children, ill or disabled family members, and unemployed working-age adults. So in such instances, the presence of an older person may add and supplement and increase the existing care responsibilities. And even though an old age grant can provide financial security in the household, the state pension is not present in all contexts within the region. So while there are high levels of unpaid care work, more women at the same time are also engaging in paid work. But despite women's participation and increasing participation in the labour force, the division of performing and financing care remains highly gendered. So it's these cumulative care needs, both practical and financial, which are extensive, that need to be understood when thinking about the care of older persons. So the benefits that an income or an old age grant brings in are often limited by the number of dependents it supports. Now, the other part of inequitable practices and thinking about how an inequitable practice exists largely relates to knowledge production and the political rhetoric that surrounds care in families more broadly, but specifically for older persons too. It's critical to highlight the gaps in data and evidence in the region. Whilst we recognize, and I recognize, the complexity of doing longitudinal, nationally representative survey on older persons and caring for older persons, in contexts that are characterized by complexity and fluidity, there are almost no large-scale surveys taking place, and they're also very difficult to conduct in such contexts. So the majority of research conducted in the region is focused on South Africa, and there are very few regional comparative research papers and evidence. Most of what we know is based on secondary data. Most larger studies are foreign funded, but there are heaps of data and knowledge produced in either unfunded or underfunded and unpublished doctoral research. So if we think about these huge gaps in what we know about family caregiving, it goes to show that policy documents are being based on the assumption that the family will and can care. Currently, we have grave concerns that policy is not informed by evidence and knowledge of inequitable care practices, which is not only pointless, but is very dangerous for the caregiver and receiver. At the same time, what is featured in many policy texts are dominant discourses on strong families, intergenerational solidarity. So inequality and inequitable care practices regarding the care of older persons stems from the ways in which discourses on family care for older persons are being misused and manipulated. So on the one hand, we draw attention to the familialist policies in the region that focus on normative expectations that people are supported by their families, while on the other hand, we reject the largely standardized discourses that families are fragmented and older persons are isolated and neglected. And that such evidence, quote unquote, demonstrates changing value systems and an increase in individualization. So I call for more complex and nuanced understandings of the ways in which families care under a crisis of social reproduction, where high unemployment, rising acute illness amongst the elderly, and post-independent economic and social policies have increased the demands on families and family resources. So whilst familialist policies are often accepted as, being based on interdependence, understood through the African philosophy of Ubuntu, which is expressed as a cultural ethos and core societal belief, customary expectations to care for others, especially for older persons, is a moral duty that we recognize. In the courts, we see it has been used to argue for particular judgments or outcomes in the courts, where the judiciary recognized that failure to provide for older persons is a morally reprehensible act. And if a child or adult child would fail to support an older person, it could be ostracized and looked down upon as a person who had no Ubuntu. Now, writing on the concept in the South African context, feminist scholars have distinguished between Ubuntu talk and Ubuntu do. So although Ubuntu talk may embody values of equality and dignity in caregiving, and are featured heavily in policy texts, this may not translate into practice in context of social inequality. So it would be argued that a critical perspective of care is also necessary so that inequalities in care can be understood and challenged. Now, the second part of the argument and thinking around unsustainable care practice means that we need to look at the social circumstances of older persons in context. So in order to understand the ways in which care practices for older persons are unsustainable, one needs a sense of range and variation of the care context for older persons within and across the region. So most importantly, it's critical to remember that the Southern African region is far from homogeneous. The various countries displayed here in this table, South Africa, Zimbabwe, Botswana, Namibia, Lesotho, Zambia, Malawi, vary in most general economic dimensions, as well in the particulars of their policies to older persons. So, for example, the region includes countries with high GDP per capita, very little official development assistance, smaller rural populations, and low absolute poverty. But it also includes very low-income countries with large ODA, high poverty rates. And some of the countries have large populations like South Africa, whilst others have very small populations like Lesotho and Botswana. Now, in some countries, regardless of those differences, in some countries and across the region, particularly if we look in the South African case, by 2050, older persons will represent almost 20% of the population. So planning social care infrastructure that will cater for growing populations of older persons is critical for all countries, but the social makeup of the growing population radically differs. So for example, the proportion of older persons living in rural areas is very diverse, with many low-income countries having much larger rural older populations. And this would obviously have implications on access to a range of services, as older people in low-income countries have trouble, particularly in rural areas, obtaining clean water, food, hygiene goods, or chronic disease medication and mental health support. So here we can notice degrees of vulnerability within countries across urban-rural divides, but also across low and middle-income countries within the region. Most notably, too, the spread of countries also includes countries with widespread pension and other cash transfer programs such as Botswana, South Africa, Namibia, and Lesotho. But it also includes countries which have been very slow in expanding programs such as Malawi and Zambia. So upper middle income countries like South Africa, Botswana provide for most citizens by providing means-tested benefits to not only older persons, but also people living in living with disabilities and children, as well as some feeding programs. And there's very little protection for older persons in low-income countries, with Lesotho being an outlier in that regard. Social assistance programs in upper middle-income countries are not only more generous, but their coverage is far more extensive. And perhaps as a consequence of this, the labour force participation rates of older persons again varies dramatically, with older persons in South Africa having the lowest labour force participation rate. Notably, that's excluding care work that's undertaken. But places like older persons in Malawi and Zambia having fairly high labour force participation rates. When we think about family caregiving, what is essential is to think about the makeup of households across the region, how it impacts the shape of care for older persons. So whilst most households in Southern Africa are multi-generational, the region includes countries that have a high percentage of skip generation households. And again, countries that have a much smaller percentage of skip generation households. So the variation here will reveal differences in care needs and care experiences. So if we think about skip generation households being common-ish across the region, most skip generational households in low-income countries are a result of HIV and AIDS, in which children are orphaned. And in such situations, older persons may be the primary or the sole caregiver. However, in other parts of the region, in particular in South Africa, skip generation households can be largely explained by the practice of female labour migration. And therefore, older persons may still be caring for and co-residing with younger generations, but they may also be supported both practically or financially by other members of the middle generation. So supporting the care of older persons as sole caregivers or co-caregivers who have different needs and responsibilities is critical in understanding care for older persons. There's also considerable variation on which states have national legislation on older persons, which states have a national long-term care policy and plan. Again, low-income countries have not yet implemented much legislation or policies on the care of older persons, despite international WHO, the Global Strategy and Action Plan on Aging, for example. Now, this culminates to think about the unsustainable practice and the reliance or the over-reliance on female family caregivers for long-term care in the region. So what is the cost of relying on female family caregivers, and why is it unsustainable? Well, as we saw from our examples, family caregiving can cause significant financial hardship as women struggle to balance competing work and caregiving priorities. Moreover, given the number of women who work in low-income precarious jobs, who are unable to take time off without losing income or their jobs, overburdening women in such circumstances with additional care of caring for older persons will be hugely detrimental to the women's agenda and the transformative agenda in the region. So the racialized and gendered implications of not supporting carers of older persons, particularly women engaged in employment, either in the formal or informal economy, will have huge implications. So as the number of women in the labour force increases, placing all responsibility on female caregivers, is again, especially in low-income households with little state support, is deeply problematic and cause significant physical and emotional strain. As research from elsewhere indicates, there are also extensive health implications in being a caregiver. So families require, and women in particular require, adequate respite care. Now, if the family system carried by women protects the formal health system, these policies need to be in place to prevent the health system from being overburdened, particularly as we move into a rapidly aging population. So if we were to think about transforming care practices for older persons in Southern Africa, what needs to happen? Well, we are focusing on the care of older persons and social policies directed at older persons. This has to be understood within the context of the broader character of the economy, the public policy and care needs. So I recognize that policymakers face choices between what interests to promote and also what policies to prioritize. In some of the countries, the portion of older persons is tiny compared to the proportion of the population who are characterized as young or youth. So we understand that policymakers committed to improving the care of older persons also have to recognize and have to choose on how to allocate scarce resources between individuals, households, youth, old, and in some cases between agricultural production and care. But what the state does need to consider across the region is how it can provide and support the conditions under which caring relations can prosper. And if these conditions are being met, the population involved, both carers and recipients of cares, would report positively on the efforts to care. Most importantly, policies promulgated at the caring about level must support the work of those doing the person-to-person on-site real work of caring for older persons. And it's for this reason that it is essential to understand care for an older person within this broader network of care responsibilities. In some households, care responsibilities are limited to biological children and parents, but in others and in many households, the responsibilities stretch to include nephews, nieces, adult siblings, aunts, and older uncles. Furthermore, care for an older person in South Africa occurs in highly disparate contexts. In many households, there are extensive care needs, but very limited resources. And whilst cash transfers are welcome, often they are not enough. There's a great deal of variation across the region in what states can do and how they should focus their energies. But there's also a great deal of variation in family care and the context in which it occurs. And it's for this reason we would push for a broader package of policies, both within each country, but also across each country, that would better support the variation in family care practices in different households, different income levels, and different geographical and care settings. Moreover, there's also a huge need for more funding and political will in supporting evidence-based research on family caregiving of older persons across the region. So policymakers need to base their proposals more on a grounded knowledge of the actual need for care. This would refine policy insight about what is actually going on as experienced by those who are implied in these practices, both as givers and receivers of care in a broader sense. So current policies to support families are based on familialist assumptions and the normalizing idea that families provide care. And whilst this is true, policies still need to be attentive to the needs of carers and care receivers. So the silences or inactions of the state and the lack of evidence informing policies underscores the norm that confirmed the private work of care. Effectively, these inactions and normative assumptions deepen an already highly gendered and racialized division of labor, and it shapes the impact of it specifically for low-income caregivers and receivers. So to conclude, when we think about this unsustainable and inequitable care practice for older persons, the research is showing us and is highlighting the myriad of ways women cope to meet the needs of dependent persons and older persons with little assistance from the state. So that current practices are not only inequitable, but are also increasingly unsustainable as we consider the needs of an aging population in highly unequal care contexts. Thank you.
Good morning, everybody. Good evening, Elena. Good evening for you, Professor Moore. Thank you very much for that excellent conference that you give to us. We have not yet any questions, so I encourage the audience to make some, and we wait a couple of minutes. And thank you very much on behalf of the Scientific Committee of the World Congresses of the AGT.
Thanks very much, Jose. I appreciate it. And it's great to be here.
Thank you. Okay, we have no questions. Just to speak between us, do you see in South Africa during the pandemic some gender or differences in the health and social system to attend people, for example, if they coming from, poor people, etc. You have big difference in your country, or you can afford that in a good way during the pandemic, because it's one of the I think one of the cornerstone in every health system in the world, despite the type of the kind of health system, public or mixed or whatever. So if you can resume briefly your experience in South Africa.
Sure. So just if I understood you correctly, you're looking for the racial or ethnic diversity in terms of accessing healthcare, or particularly during the pandemic? Yeah.
Yes, exactly.
So I suppose similarly to across other areas in the global south, the vast majority, and I say the vast majority of the population, and that would be majority of Black South Africans too, cannot afford private healthcare, and so therefore are at the hands of the public healthcare system. As many of you may be aware, there's current talk about developing a kind of united national health kind of interdependent system, and where that goes, we're not sure just yet. It's not yet fully developed, or it's been tabled as such. So what you do see is a huge expense and huge personal individual costs going into healthcare insurance for those who can afford it, both in terms of older persons, but also across, whether you're about to have a child and you're pregnant, the types of healthcare you can access is highly dependent on pretty much on income levels, not exclusively racial. It is racialized given the history of the country, but it currently manifests itself quite particularly with regards to a highly unequalized society and huge discrepancies in regards to income levels of what people can access. And again, the regional differences are quite vast as well in terms of rural-urban divides.
Yes. Okay, the same experience with some little differences with the other the other part of the world. There is one question from Dr. Juan Pablo Negrete, that is, could you expand a little more on what is Ubuntu?
So Ubuntu is a common African philosophy and understanding, a way of life across much of the continent, but particularly to Southern Africa. And it's a philosophy. It means we're interdependent. I am because you are. Okay. So it's a deep relational sense of understanding personhood, of how we are not individuals, we are not autonomous, we are not, separated from one another, but we work together, and we are not just because of COVID-19, which the broader world has spoken about. We are fundamentally interdependent, and it's so as a result, it is a moral duty for all of us to support others, how and whenever we can, and that's particularly strong ethos. It is a cultural ethos, as I mentioned, particularly among Black South Africans and Southern Africans. But it's also been socially engineered in terms of the need to be interdependent. So given the high levels of poverty that are, again, historically kind of created, the levels of interdependency are now critical for people to sustain a livelihood, to survive. So whilst the cultural ethos is there, and whilst it's a particular philosophy and way of understanding personhood in particular, it's also being engineered. I mean, not so much the philosophy, but the need for interdependence.
Okay. It seems like a real community must be, it's very interesting as his philosophy. And this works?
You see, this is the problem, and I think I alluded to this a bit in the presentation. Whilst it is a philosophy, it's embedded in the constitution of South Africa. There's also a stark reality of the differences between talk about Ubuntu and discourse around Ubuntu, that we should be supporting each other, and actual practice of who is actually providing care, financing care, giving their time, sacrificing, etc. And we know the gendered and racialized, highly racialized story of that, whether you're looking at older persons or other vulnerable, populations across the country. And so feminists, and African feminists in particular, have spoken up to examine the differences between Ubuntu talk and Ubuntu do, which is, what we see on the ground, the reality.
Yeah, that's really, really, okay, the philosophy really matter, but the reality in general is the only true.
Yeah.
No?
But it has a very strong, powerful, and I say it's more than just a discourse. It has a very strong, powerful discourse in political circles, amongst the political elite in particular, but it also features widely in the courts, in the judiciary, in civil society. So it's not, it's not just an aloof philosophy that people, it's really used, but often used and misused and abused when it's convenient to do so, for other people to step back.
Okay, it's an ancient philosophy, or began with the Nelson Mandela period of presidency?
No, it's ancient. It's absolutely ancient. It precedes Mandela. It precedes, the kind of, it's much, much older and deeply embedded in a pre-colonial society, let alone colonial and apartheid and then post-apartheid society.
Okay. Well, I think we have no more questions to you or for you. So thank you very much again, Elena. It's a pleasure that you'll be with us today. So congrats for the conference again, and thank you very much.
Thank you very much, and I really appreciate the time and the support of all the team. And I wish a very good conference for everybody else.
Okay.
Thank you.
Bye-bye.
Bye. Thanks.